That's,
Yes.
that's really nice.
Yeah.
Well, who wouldn't want to hear
I say
from like
Katrina
the
draws a crowd.
Oh,
Always.
thank you for saying that. I have to remind my husband that people actually do actively want to hear me just talk at them because, you know, sometimes he forgets.
uh,
I'm like,
That's
for you, I'll
amazing.
do it for free, honey. You know?
That's amazing.
that's awesome. Well, please say hi to Dale for me.
I will. I will. He sends his best. He just zipped in and did like a wave.
Uh,
He's wearing sweatpants, so he's not going to come and say hi, but
Yeah.
he sends his wave to everybody.
We all have one, you know, in the family.
That's right. That's right. Oh.
Well, we were talking earlier, we have such a mix of our audience today. We have people that are brand new coming to an ACT Masterclass for the very first time. We have returning guests. So welcome, welcome, everybody.
Mhm.
All right, Katrina, I hope you don't mind, but I am going to turn my camera off and
Of course.
listen intently. But it's so great to see you, and it's
Good to see you.
you know, it's great to be here with the whole ACT crew. Barrett and Angela, you guys are awesome, and
Thank you, Steve.
Miranda, of
Thank
course.
you.
Yeah. Thank you,
Um,
Steve. Good to see you.
Yeah, great to see you.
Barrett, do you want to kick us off?
Yeah, let's do it. Let's get going. Well, I have the pleasure of introducing one of Axe Dental's best friends, Katrina Sanders. All of you probably already know who Katrina is, but she's a hygienist. She's an author. She's an international speaker, and most importantly, she's a wine enthusiast, as we found out with the German mulled wine. I think she's one of the best dental educators regarding hygiene in the country. And what I appreciate the most is she always challenges us to think a little bit differently about how we treat our periodontal patients. So I promise we're going to have a great day. I promise we're going to learn a lot. I promise that you're all going to go home and have some really clear ideas of changes you want to make to your periodontal program Monday. And that's ultimately the best compliment I can give any speaker is you leave with advice that you can implement the next day. That's my favorite thing about speakers. So without further ado, Katrina, we're always so grateful to have you here, and take it away.
Oh, thank you so much, Barrett. I so appreciate that warm introduction. For those of you who had logged in a bit early, you probably heard all of us kind of kibitzing early on. I'm actually from Milwaukee originally, so it is always, always, always a pleasure to work alongside the ACT Dental team. They bring me home a lot, and they always roll out the red carpet and make it such an incredible experience. So, in a way, I feel like anytime that I'm working with the ACT Dental team, that I feel like I'm working with family. So it is an honor to be here, and hello and a happy December. Actually, sorry, I just saw this little hat here. So this was unplanned, but I figure let's get into the holiday spirit a little bit. Literally unplanned. I just saw this hat here. And the reason why I think this conversation is such a monumental one, or an amazing opportunity to have now, is as we're approaching the end of the year, I think it's always a great time in dentistry, across dental practices and clinical teams, to sit down and kind of do a review of, hey, what happened over the year? Where did we achieve success? Where did we see development and growth? Where did we see amazing opportunities? Where did we have wins? And what were those wins? As a clinical hygienist, for me, my wins may look a little bit different than a practice owner like Steve Spitz. So for me, a win would look like I was able to achieve or help my patients achieve as close to 100% health as possible. Now, I don't mean to say that our doctors don't believe that, because of course they went to dental school and that's exactly what they want too. But their metrics they're looking at will likely be things like production goals that were achieved, your big, hairy, audacious goal that you've just knocked out of the park because you worked with the ACT Dental team and they helped to support you in optimizing that. But one of the things that I find that really creates such amazing synergy and alignment particularly when we're talking about the individuals who find themselves attracted to the ACT dental community, is the fact that doctor practice owners inside of this community believe that if you do the right thing, the production will follow. And I think that's why I feel so aligned with the ACT dental community, is because that has absolutely been my motto from day one. You do the right thing, educate your patients on what you're seeing, capture the appropriate assessments, help them understand what it is that you are seeing, help color the narrative or fill in the gaps in the science heavy confusions that your patients may have, and ultimately give them the opportunity, the autonomy to decide how they want to move forward with their level of care. And I think it's such a timely dialogue. And I hate to share this. We know that a few days ago, there was an assassination of the United Healthcare CEO. There are a lot of anger, feelings, and frustrations around how patients and providers alike sometimes feel as though we are pushed up against that third party reimbursement. I think a lot of times there are fears or challenges about what will my patient think, or what will they say, or how upset will they get if I put in front of them a treatment plan that requires them to pay anything out of pocket. How deeply will they question the integrity of the diagnosis that I gave them? And dentistry, I'm going to tell you something I think a bit hard for all of us to swallow. And that is, we as a community are not as well calibrated as I think we would like to be. Put simply, a patient could come in, sit down in my chair. I could perform a comprehensive hygiene exam on that patient. Comprehensive, top down, evaluating everything from their radiographic findings to their clinical assessments. And I could spend a large portion of time educating my patient on what it is that I'm seeing. I'm concerned about the inflammation in your gum tissues. I'm concerned about the infection in your mouth. I could utilize all of this verbiage to help color that picture for my patient. And the reality is, my patient could get upset. They could leave the practice, not accept any treatment, go across the street to another dental office and say, I would like a second opinion. The hygienist across the street wanted to do a deep cleaning on me. They wanted to charge me out of pocket for these quadrant scalings, and I don't think I need it. And I hate to say it, there's a dental office out there that will absolutely see that patient, perform assessments, and say, I'd be happy to do that regular cleaning for you. There are dental practices out there where they might either practice from a different standard set or be far more tethered to giving the patient what they're asking for versus empowering the patient with the knowledge and the education that they need to have in order to make an appropriate decision about the level of health or disease in their mouth. So here we are, the end of the year, taking a step back and looking at, okay, so where were our wins this year? Where did we achieve success? And on the clinical side, I do believe that achieving success is moving as many patients to 100% health as possible. The other side of this is looking at where are those opportunities? And those opportunities are seen in things like, when did we not achieve the health outcomes that we were looking for? That could be we performed the level of care that we believed the patient needed and they didn't respond. It was the periodontal therapy we did was not successful. The, root canal therapy that was done was not successful. We had to refer that patient out. We attempted to do a Hail Mary MOD, QRS, TUV, and it didn't work. And now we need to be doing some kind of a full coverage. So sometimes those are clinical challenges that we believe are within our circle of control. But sometimes those clinical outcomes are based on, or rather the lack of clinical outcomes are based on patients who didn't accept the treatment plans we put in front of them. And I think the hard thing in dentistry is realizing that when a patient doesn't accept our treatment plan, that part of it is money and part of it is them actually questioning our clinical integrity. Part of it is them questioning, do I really have this disease? And part of it is them questioning, how serious is this? Is this something that I need to have addressed or dealt with immediately? So today's program is the first of a two-part series. So please consider joining me and the amazing Act Dental team in 2 weeks for part 2. But this first program, part 1, is kind of diving into some of the innovations that we're seeing in the provision of periodontics. And I call this hygiene exam essentials because while we will be talking about implementation, what we're really talking about today is what treatment modalities do we have available that help color the picture for our patients about the level of disease that we're seeing in their mouths. How do we create a talk track and how do we develop a care plan for our patients where the patients understand the serious nature of the disease that's occurring in their mouths? How do we create a talk track and how do we build a plan that helps the patient understand this is, in fact, something that I do need to have addressed? The challenge for us in dentistry, particularly when it comes to periodontics, is the fact that the disease we're talking about does not hurt our patients. And unfortunately, alongside that, we see that showing up in things like the prevalences of disease. So this is kind of a rough gathering or smattering of data. This is combining the data that we saw in the 2016 CPITN score or evaluation of the prevalence of disease of adult Americans. So currently, we know that about 47.2. So again, forgive me for these kind of raw numbers, but we believe that about 47.2% of our adult patients between the ages of 30 and 79 have some form of periodontitis. And I think that when that data came out, that I think was quite shocking for dentistry. I think that was quite shocking for providers because when you actually take a look at the amount of prophylaxis procedures that are being done in an average general dental practice, I think it started to open up the door to consider, oh my goodness, if almost 1 in 2 of our adult patients have perio, then does that translate? Are we doing 50% of our procedures in a hygiene column? Are we doing either active periodontal therapy or moving them into a maintenance? And so that was really kind of the eye opener. I want to be very clear, this data continues to escalate. So this was done in 2016. The world, according to Katrina Sanders, is this number probably higher coming out of the 2020 COVID pandemic? Possibly because of the delays in dental visits, people wearing masks and the ramifications of mask mouth, etc. So this data is a bit old now. It's 8 years old. The other challenge that we saw is that the prevalence of periodontitis actually increased about 57% from the 1990s to the mid 2000s. So they captured a data set that was, kind of the mid 1990s to 2010. And when they looked at that data set, they found that prevalences of disease had increased 57%, likely due to individuals living longer and living longer with their natural teeth. So that's exciting. Us trying to control these periodontal conditions now means that patients that maybe would have had their teeth extracted and had dentures placed are now instead living with their natural teeth, but they're experiencing disease. They're experiencing, whether it be slow, moderate, or progressive levels, they're experiencing an activity of the disease process. And we have to figure out dentistry. How do we educate these patients who are routinely coming in every 3, 4, or 6 months? How do we help these patients understand the level of disease in their mouth? Alongside this, we look at the remaining patient population. And again, these are just rough scores. About 93.9, almost 94% of individuals who don't have periodontitis have some form of inflammation in their mouth. And specifically, 55.7% of those individuals have a gingival index over 1, meaning they have generalized moderate to severe gingivitis. So all this really means when we look at a big spectrum of all of our patients, that about 47% of our average patient population in a general office will have perio, 28% presenting with that moderate to severe gingivitis, which puts about around 25% or 1 in 4 of our adult patients presenting with either a state of health or, as the AAP is now classifying or outlining, incipient or mild forms of localized gingivitis. So this prevalence of disease becomes a big challenge because as we continue to see these levels of disease rise in our patient bodies or our patient populations, we run into the other side of the coin, which is a large portion of patients who are presenting for a routine cleaning are not expecting that they're going to be sitting down in your chair for their routine hygiene visit and be told that they do, in fact, need to have periodontal treatment done. So this becomes the challenge, dentistry. A large body of our patients who think that they are in a perceived state of health, a large portion of our patients where their gums don't hurt unless you poke them in the mouth skin with that tiny little sword, of course. A large portion of our patients do not believe that they have an infection because they believe that they're asymptomatic. So part of the challenge is when periodontal disease does not hurt, and we sit down with our patients and they're expecting to get their free cleaning their insurance covers. And we have to now explain to them that they do, in fact, have a periodontal condition, and that instead of that free cleaning that Blue Cross Blue Shield of whatever, Delta Dental of whatever decides that they will pay, instead, now we have to give that patient a treatment plan for non-surgical SRP. And I hate to say it, we've all been there. We've all been there where we're trying to explain to the patient and the patient gets heated. And not all patients are going to yell at us. The loud ones will, the frustrated ones will. On the disc profile, the high Ds will. And the challenge here is that the patient is upset for likely a myriad of reasons. Frustrated at you because you're the messenger and they're shooting the messenger about the level of disease in their mouth. But there, as we're going to learn in a minute, are other layers to what happens when patients get frustrated. They're questioning our authority, they're questioning our integrity, they're questioning our level of knowledge and understanding about their disease. And unfortunately, they are specifically questioning if they even have this disease or if we are simply giving them a treatment plan for something just so that we can bill them more. That integrity becomes a major issue. And as you'll find in a minute, is actually a key driver for what causes patients to say no. Now, not all patients are going to yell at us like this. Some patients will simply say, and this would be my husband, thank you. Yeah, I'll take this treatment plan home and I'm going to go ahead and talk to my wife about it. And many of us have heard that the number of times that they go home and actually talk to their wife about it versus throwing that treatment plan that you just printed out from your Dentrix software or whatever, they throw that in the back seat and the wife discovers it a couple weeks later when she's cleaning out the car. Or if they even say, take a load of this, look at what Dr. Smith wants to do today. Holy cow. I'm not doing this. I'm just going to go and find another dentist. And so we see a whole host of ways in which patients being surprised by this can create complications for the office. The easiest for a patient who doesn't agree with our treatment plan, the easiest thing would be for the patient to ask more questions and to say, so did this come up overnight? How did I get this? What are the risk factors that put me in this position? Are there things that I can do to help control this? Is this something that I can manage on my own? Will this go away on its own? Or is this something that I actually do need to have treatment on in order to have it addressed? How elective is this procedure for me? Do you believe? The other side of this, or the other challenge around this, particularly when it comes to our patients, is that although they may not be asking questions, The patients who choose to leave the office also create risks. What if they leave the office and they get a different treatment plan in another office and the patient files a complaint with us? What if they put something bad on Yelp or Google reviews? What if they file a complaint with the board? Even if we did do all the assessments correctly and the patient does in fact have periodontal disease, nobody wants to go down to the board and have their name on all of the paperwork, being at a quarterly board meeting where your colleagues are opening up your paperwork and looking at how well you took these radiographs and diagnosed this patient. Nobody wants that. And so I think the challenge for dentistry is that we feel quite inclined to ensure that our patients are happy. I think we feel very driven or motivated to help our patients get what it is they think they need. And for a lot of practices, when a patient is upset and they decline periodontal therapy, this is their next go to. Their next go to is, okay, so we'll do your 4 bite wings, we'll do your exam, and we'll do your pro fee. These fees, by the way, I captured from Forbes.com. So depending on the kind of practice that you're in, your UCR, et cetera, obviously these fees are going to evolve and change. But on average, these are the typical fees that we're looking at for reimbursement from the average third-party payer, which means that in that appointment, a dental practice is walking away with around $222.71, $223 for an annual revenue of that patient being less than $500. That patient is taking up at a minimum 2 hours in your hygiene column per year. But the major challenge is not necessarily the production that's coming in, but the legal liability that it is possessing inside of your practice. And the other side of it too becomes the fatigue or drain on your practice core values. Kirk talks a lot about core values in the ACT dental community, and it's one of the things that I deeply appreciate about what he does. Your core values in your practice are really important because they set the tone for what the practice owner or what the practice team believes is going to be important when it comes to decision making, providing optimal care to patients, customer service, etc. Well, I'll tell you, for me as an example, I work in a large group periodontal surgical practice where excellence is one of our core values. Integrity is another. So if excellence and integrity are two key critical core values in the practice that I work in, and now I'm being told to just do a pro fee on a patient who has active periodontal disease, if I'm being told, go ahead and have this patient sign an informed refusal form that holds no water in a court of law, and I'm expected to perform that pro fee, then respectfully, the doctor clinician who told me to do that is, in a way, violating their own excellence and integrity. And so those drains on the core values of the practice create a lot of confusion for the team. It creates a very questionable leadership style in practices. And unfortunately, it sends a message to that patient that ultimately our clinical skills mean very little. Our clinical opinions, the rigor of the education that we receive really means nothing compared to making sure that they're happy. And I think we can all agree we want happy patients, but we want healthy patients as well. So the challenge then becomes, why is it that patients decline their periodontal treatment plans? So this is an awesome study that was done by our friends at Orapharma. This was done several years ago. And then our friends at Pearl actually replicated this study and captured the same results when they replicated the study. So here's what happened in the study. They interviewed patients, hundreds of patients in the study, and all of the patients in the study had one thing in common. All of the patients in this study went in for their dental visit. They were all diagnosed with active periodontitis, and they all received a treatment plan for non-surgical SRP and delivery of antibiotics, subgingival antibiotics. Orapharma is the maker, is the governing body or company that makes Arestin. So all several hundred patients in this study declined their treatment plans. They said, no, I thank you for the treatment plan, but no, I just want my free cleaning my insurance covers. And or pharma in this study, and Pearl several years later, when they replicated it, wanted to know why. What was the number one reason why you declined that treatment plan? So I love doing this because and for those of you who have seen my programs before, you know the answer already, but I love going into rooms with dental clinicians there and office managers and administrative team members and asking them, what is the number one, what do you think, right? I love asking the treatment coordinators, especially because they're in it, right? Why is it that you think that patients decline the treatment plan? And, the patients had in these surveys had like a zillion different, options. They didn't want the needle. They were afraid that it was going to hurt. They were afraid it was going to be sensitive. They didn't believe they had gum disease, um, money, insurance reimbursement, or the lack thereof, having to pay out of pocket. All of those things were options. And when I ask the dental community, what do you think the number one answer is? I cannot tell you. It is like an echo, a chorus of dental professionals that all kind of rise up and say they believe that the number one reason why patients decline their treatment plans is because of money, because the insurance plan doesn't pay 100%, that it'd be a lot easier if we did this, treatment and insurance paid 100% of it. And wouldn't you know, the number one reason, and again, this was replicated by Pearl, and they captured the same data when they did this in a study several years later. The number one reason why patients declined their treatment plan, resoundingly, is that they did not trust their dental health care professional. They didn't trust us. They questioned something about what we were doing. And here's the challenge. Clinically, we know that if a patient has active disease and we choose to do what the patient is asking and perform that free cleaning their insurance covers, that therapy is not therapy. It is preventive. It's not therapeutic. It is not a procedure that is going to help to address the underlying condition. But I think the narrative we've been telling ourselves for a really long time is that something is better than nothing. So, for those of you who know me, I'm a big research nerd. I love looking at the science, and I went on this like personal self-discovery journey as a periodontal hygienist who gets really frustrated when patients ask for this free cleaning. I actually wanted to know clinically, is something better than nothing? Okay, so I will call out the research that I capture all of my data from is denoted in small print down at the bottom of all my slides. So I promise I'm not making this stuff up. So this was a research study that was done, is actually just recently done. And this is kind of what was like the gateway for me really diving into this, and fingers and toes crossed that we're going to see more and more data come down in this. So this was a study that looked at, okay, what happens if you perform supragingival scaling? And the concept here was actually looking at a problem that we see in a lot of dental practices where a patient will come in for their, hygiene visit, for their recare visit. The hygienist identifies this patient as active perio. And then you look at the clock and you go, okay, well, all these assessments and x-rays and bringing the doctor in for the diagnosis and all of that has taken 35 minutes of this appointment. So technically, I've got about 25 minutes left. Do I do something? Do I do at least a prophy today so the patient feels like they got something? I think that's the question a lot of hygienists have. I think that's the question a lot of office owners have is, do I expect my hygienist to do that? Great. At least we can bill something for that hour, because x-rays and an exam may not be enough. Stay tuned, friends. Stay tuned. Stay with me. We're going to get there. So the question really begins with, should we have the hygienist perform a prophy before doing periotherapy? And the data looked at this and said there's actually no significant difference. If you perform a prophy and then bring that patient back a week later, 2 weeks later, whatever, we don't see better clinical outcomes if the patient had a prophy up front. So that's the first thing. That is the first data point that we, in fact, needed to take a look at. As we dove a little bit further into the studies around this, we had to look at the microbiology of supragingival and subgingival plaque. So the concept here being that supragingival plaque, we know, is a good primary factor for gingivitis. And that is an overt concern, of course, that we're looking at. When we talk about periodontitis, however, we know that supragingival plaque is not the driver for the development of periodontitis. So, without going too much into the microbiology, I know it's a little bit early on a Friday morning. Everyone grab a sip of coffee here. It's a little bit early on a Friday morning for us to really go into the microbiology and the pathophysiology of all of this. So, I'll save you the microbiology lesson, although I'm a huge microbiome nerd. It's like one of my favorite things in the whole wide world. But it's important for me that you know that that supragingival plaque drives the early development of gingivitis. Once gingivitis occurs, that inflammation occurs, or that gingival enlargement, we start to see the maturation of subgingival plaque. And subgingival plaque is entirely different from supragingival plaque. The makeup of the bacteria, and we know that, right? We know subgingival plaque is, gram negative, it's anaerobic, it has to live in an environment without oxygen. That bacteria have their own microbiological processes to them. They release toxins, they have virulent factors to them, they release enzymes, they have these OMV, these like capsules around them that are, communication channels, like all this crazy stuff, right? This subgingival plaque is dynamically different. So when we see a patient who's presenting with periodontitis, if we're doing a supragingival debridement specifically, and we're not really focusing on articulating into the anatomy in the subgingival space, we run into challenges. Okay. Thank you for going on that microbiology journey with me. So then we started to look at what happens when the patient has an instrumentation of the supragingival site. Do we see any changes subgingivally? Do we see any changes with the microbiome? Like, is something better than nothing? Let's say we do a prophy on that patient, and let's say the patient just never comes back for their SRP. So if we at least did something, is that better than nothing? Did we get some kind of an improvement until the patient reappears in our hygiene column? Well, this data looked at that and specifically said that if a supragingival scaling is done, that initially we'll see a slight improvement in supragingival plaque scores. That's obvious, right? You remove the biofilm from the supragingival space, we're going to see an improvement in plaque scores. But here's the problem. If supragingival scaling alone is done and we don't get underneath that gingival margin to the base of whatever that probing depth is and effectively debride all of that, we've actually seen that gingival bleeding scores will increase. And the frequency of periopockets at 4 millimeters or greater will significantly increase as well. So the challenge here is that something may not be better than nothing, if that makes sense. Conversely, we also looked at the microbiome. My apologies for this light pink font here. We looked at the microbiome, and what we found is anytime that supragingival debridement is done where there's a periodontal site. Okay, so I want you to think about this. Patient comes in, they've got a couple of localized 4 and 5 millimeter probing depths, and that is true apical migration of the junctional epithelium. That is a true pocket. That's not necessarily enlargement, although we do know that when you get gingival enlargement in a 5 millimeter probing depth, that there is a subgingival microbiota going on, right? We know that to be the case too. But if you're only performing supragingival debridement, you're not getting entirely to the base of the probing depth and debriding all of that out. We've actually found that there is a stark increase in Porphyromonas gingivalis. So when only supragingival control is done, it fails to address the further destruction of the periodontium. Now, we're talking locally today, but it's important to know that once we see an uptick in P. gingivalis in the subgingival space, we know that that doesn't remain locally, that P. gingivalis, who's kind of the queen bee of the red complex, she's got a lot of microbiological processes going on. P. gingivalis has, gingipanes and various types of enzymes that can be released. P. gingivalis upon entering the bloodstream, upon, being concentrated inside of the saliva, upon being aspirated into the lungs, can do things like create plaques in our blood vessels, in the lungs, and even in the brain, which is where we see the sequelae of Alzheimer's disease creating an issue. So the challenge here really becomes, folks, that if we're looking at patients who are presenting with disease in our chairs, and we're holding back on educating our patients about that level of disease, if we're holding back in educating our patients on specifically what it is that we're seeing, and subsequently, if we're not giving them the appropriate treatment plan so that they have the autonomy to decide, we might be creating a bigger issue or challenge down the road. And so today's program is diving into that, making sure that we are capturing appropriate modalities inside of that hygiene examination and doing so while properly communicating with our patients. So, my name is Katrina Sanders, and it is an honor to be here today alongside the amazing Act Dental team. Yes, all of that was just my introduction. Can you believe it? But it's important for me that we set the tone as to where we're going inside of all of this. So, I am a contracted speaker with the amazing Act Dental team. It is an honor to be here. I have included a QR code here. This QR code will actually grant you access to a free web-based program that I created and presented a few weeks ago, updating on the 2025 ADA CDT codes. In that, I also walk through a thought process around some clinical decision making for hygiene patients. So that's a free webinar that you have complete access to just by scanning that QR code. Feel free to join us, use it, metabolize the content. It is my free gift to all of you, as of course, we're talking about the holidays and gift giving. I'm also here today after the receipt of an educational grant from some amazing partners. And many of these are amazing partners alongside the Act Dental team as well. Pearl, Waterpick, BioGaia USA, the amazing folks at Microbe Link DX, and Perio Protect. Today's program is going to begin the conversation. I mentioned this is part one of a two-part series. So we're going to begin the dialogue today, and check that chat box because I know that they zipped into the chat box the link to join us in 2 weeks for part two, where we're going to continue this dialogue. We're going to be taking a look at some of the innovations in periodontics and our ability to capture and enhance patient engagement. Ultimately, when we talk about the provision of periodontics, my hope or my goal is that we have the opportunity to create a far more broad stroke educational platform for our patients, helping them to understand what our goal truly is. I think that is the missed opportunity in educating our patients. My goal as a periodontal hygienist, as a practicing wet-fingered periodontal hygienist is, and I've said this several times during this introduction, to move as many of my patients to as close to 100% health as possible. That is my goal. I do have other goals. I sit in morning huddles where we have big, hairy, audacious production goals. We have treatment planning bonus goals and all of those things. And I want to separate ourselves from those goals just for this two-part series to simply say, if you do the right thing, those production goals will come. Doing the right thing for our patients helps to mitigate the biggest challenge, the biggest roadblock that gets in the way of our patients saying yes, and that is trust. Trust is built on pillars of integrity and showing your patients that you care. And so today we're looking at that goal. How do we create an exam? And again, we'll talk about some of the success of treatment outcomes, but what we're really doing today is talking about the talk track. How do we how do we build the narrative so that by the end of that appointment, whether that's a new patient exam or whether that's a recare exam, that by the end of that appointment, the patient walks out that door saying, I've never felt more heard or listened to in my life. I've never had a more thorough exam. I know that the clinician who did this exam looked at everything, sat down with me and explained all of this. And I know that the plan that I'm holding in my hand is one that was carefully and methodically thought through. They designed this plan for me. That is the level of care that patients are expecting us to deliver in 2024 and beyond, is a patient-centric, customized, unique care plan that is designed to meet their needs. So while this may feel counterintuitive, what I'm telling you to do is to take that patient who wants the prophy, and I'm saying, actually, we're going to add on not only the treatment plan of non-surgical SRP or that D4346, whatever that may be, which, by the way, in that web-based series with that QR code I offered to you, we'll walk through. Not only that, but more specifically, what we're doing is adding on adjunctive or adjuvant services more. By the adding on of more, it colors the picture about how truly serious this is. And it gives us the opportunity to create long-term periodontal health in our patients. So let's take a look at some data here. This is from our friends at Pearl, and this was a survey that they did in 2022, which looked at patient trust and their trust really inside of integrating technology. About 87% of our patients say that it's important that their dental office uses the latest technology. 77% of patients are going to be more likely to choose a dentist when they use advances in technology. And that's important. Dentistry sometimes hides behind innovations or technology in their practice. Dentistry gets nervous sometimes that if they add on a new procedure, they do a new kind of assessment or a new kind of survey, they get a little bit nervous that the patient's going to go, so you didn't do this on me 6 months ago. So did that mean that you did a bad job 6 months ago? Why didn't you do this on me 6 months ago? That's always our fear, right? That's always our concern. And I will share that's a valid concern. That's a valid question to have. However, I will say, uh, this is just a personal journey for me as a woman who has a deep-rooted family history of breast cancer and is not quite 40 years old yet. Having my physician say, we have a new technology that allows us to non-invasively perform a mammogram that allows us to see deeper into the tissue and look at all of these areas in a more innovative and invasive, non-invasive, but innovative way. I'm not arguing with that as a patient. In fact, I'm delighted by that. I'm appreciative that my doctor has made the choice to do something to see things earlier, clearer, faster, and sooner. So this becomes really important. And these are going to be the three innovative steps that I want to walk you through today as we dive into some of these modalities. So I've got 3 steps to innovation. First, we're going to look at how we objectively measure disease and do so with confidence. We also need to capture relevant motivators for our patients. What actually motivates our patients? Because motivational interviewing is really built around the concept that if we can identify what drives our patient, what's going to pique our patient's interest, then we have the opportunity to create a care plan that meets that motivator. For some, it's just that they want whiter teeth and fresher breath. All good. I've got that available for you today. So stay tuned. We'll make sure that our patients walk out the door happy. Finally, we're going to look at how we control clinical outcomes and take back our time. Our time, which is, by the way, extremely valuable. It is the one thing you cannot get back. So we're going to do that by beginning looking at the assessment phase. What we're doing inside of our assessments to thoroughly, fully, and comprehensively capture assessments. Now, we're going to be walking through some of the complexities of this assessment phase between today's program and the program that we deliver in 2 weeks. But it's important to know as we take a look at the comprehensive assessment phase that I, as a periodontal hygienist, integrate when I'm seeing my patients, whether they be for a new patient consultation or whether they be a recare patient who's presenting in our practice. And I will absolutely say in a perio office, a recare patient is a 4910, a periodontal maintenance patient. They are a perio maintenance patient in a perio office. So are they prone to seeing a resurgence or refractory nature of disease? Of course, we are actively screening for that. That is why we alternate our patients back and forth between the general office and our periodontal practice. There was a research study that was done a few years back that looked, and this was quite recent actually, that looked at the complexities of different severities of periodontal disease. And in this study, they looked at how many patients who have periodontitis, so that 47.2% of our adult patients, how many of those patients have severe perio where they're being seen in a perio office? And wouldn't you know it, 11% of those people have severe perio and are seen in a perio office, which means the vast majority of patients who have periodontal disease are currently sitting in general practices. So I do want to call that out. And I think it's worth it to call it out to say, thank you as a perio hygienist who works in a perio specialty. Thank you for your referrals. We appreciate them. We know how valuable that is for us and how valuable that is for the patient. But a large body of individuals suffering from periodontitis today are not making it into a perio office. You are managing them in a general practice. And so how you assess those mild cases of disease becomes really important. The problem is what we're seeing in large chart audit studies across the United States is that unfortunately, a decent portion of patients who present into a general practice are given the 323 WNL, we never looked, perio stamp pad. And by that, sorry, for the Gen Zers, we used to chart things in paper, and this is a rubber stamp. Now it's just 323, 323, 323 on your keyboard, right? My apologies for being a bit archaic. You can tell how long ago I went to hygiene school. But for those of us who did have to get that red blue pencil out and write that 323 there, we know that when a patient presents with charting that looks like this, you open up that Dentrix or that EagleSoft appointment book and you see in the perio chart 323, 323, 323 over and over and over again. I think many of us can agree this is a clinician who did not take the time to accurately assess these patients. And this is where mild disease begins to brew. Unfortunately, large chart audit studies across the United States have demonstrated things like the concerns of, missing perio charts altogether. Or if the patient did have perio charting, one of the key concerns that we've noted is that a large portion of those individuals didn't have things like bleeding or other charting parameters included inside of their assessments. The other side of this is that even when we do perio chart our patients, a large portion of our charts don't have a diagnosis at all. So, with the exception of radiographs, which by the way, we do a very good job of taking in dentistry. Why? Because we can reimburse for radiographs. With the exception of radiographs, large chart audit studies actually indicate or denote that the vast majority of charts don't contain appropriate or significant enough data that help us to move to an appropriate diagnosis. So, this leads us to some concerning issues. We're relying on radiographs a lot when it comes to diagnosing perio. We rely a ton on radiographs, and I understand why. If you went to hygiene school or dental school around the same time I did, which was years ago, I'm not going to say out loud, you guys, but if you went to hygiene school or dental school at the time when we were, dipping x-rays in the solution and then putting it on a light box and squinting to look at it, you remember that we used radiographs as kind of the key identifier of periodontal disease. We were looking for changes in the bone. And unfortunately, data from our friends at Pearl, and this, again, incredible research study that looked at building patient trust back up. This data actually says about 65% of our patients don't actually understand what we're pointing to when we look at their x-rays. So x-ray comes up like this, and we start pointing to things, right? We start pointing. We start going, oh, well, you see that there? Well, there should be a white band, and you see how it's kind of gray there? And I don't know, that could be a little piece of calculus. And we go, oh, I don't know, over here. This could be. And honestly, what do most patients look at first and foremost? What are those white things? That's the first thing most of my patients ask. What are those white things? Okay, those are fillings. Let's get that out the gate, right? These are fillings. But what I'm looking at are these small little detailed areas. And again, it's important to know that as we look at these things and we see areas of concern the average patient doesn't. In fact, if your patients are like mine, when they look at radiographs, they say things like, kind of looks like toes, right? I get that a lot. Kind of looks like toes. A super side note, my sister is a podiatrist. She's a foot and ankle surgeon. And I've actually had the pleasure of being able to speak in the podiatry space a bit. You'd be surprised how connected the mouth and feet are. And I'm not just talking about hand, foot, mouth syndrome. So I've been to several of her conferences. And I'll tell you, I think I look at a lot of I have coursework on radiographs. I work with the wonderful folks at Pearl. So I feel pretty confident in understanding radiology. But when I go into her profession and I see these presenters who are putting up like x-rays of ankles and feet and like legit x-rays of toes, I have and their point, these are, podiatrists who are like, you see this area of gas gangrene. I can't even see it. I, a dental hygienist who does coursework, who writes coursework on this, sometimes I have no clue what they're looking at when they're pointing in their conferences. So that gives us a lot of compelling information, I think, about what's actually going on. We think that this is a good educational tool, and I don't mean to say it's not. Well, what I do mean to say is when we're pointing around, there are lots of shades of gray, pun intended, when it comes to actually what it is that we're seeing. And the challenge is a large body or portion of our patients state that they actually don't trust when we're pointing at things on x rays. They actually don't trust us. In fact, about 60% of patients say that they don't trust our x ray diagnosis. Now, that I think is pretty eye opening. Think about that. 10 patients in your column, 6 of them don't completely trust what you're pointing at. So that creates a layer of complication. Now, this is, I think, what has really created an innovative, game changing opportunity. Speaking frankly, they really shouldn't trust us. The human eye can visualize up to, 30 to up to 50 shades of gray. The human eye can visualize up to 50 shades of gray. If you are my husband's eyeballs and you're looking at shades of gray in the Home Depot paint chip aisle, because we just recently bought a house, that's probably like 2 shades of gray. Sorry, men, you're all colorblind. You can't see things. I'm joking. I'm joking. But what I do mean to say is the human eye actually cannot visualize as many shades of gray as we like or as we assume. I used to, we just moved, but I used to present in front of, my office wall in my home, at my old home. And everyone would say, Katrina, I love your purple background. It's so amazing. I love that purple background. It actually wasn't purple, it was a shade of gray. But it looked purple. So we know there can be different complexities, contrasts of that gray. Well, it turns out artificial intelligence can actually look at various shades and tones of grays in a far more impactful way. And this QR code will actually take you to learn more about what our friends at Pearl with their AI software are doing to help begin to identify these various shades and tones of gray. So the use of AI technology now allows the AI software to read 500 to up to 750 shades or tones of gray. So now instead of just pointing to, oh, do you see this? Do you see that? And the patient's going, I have no clue what you're talking about. Now you can click a button. And through the use of AI technology, now our patient sees something different. Now, when we take a look at what our AI technology is able to share with us, the computer becomes an objective means of being able to identify areas of concern. And again, this QR code will take you to the Pearl site where you can actually demo the technology and take a look at some of the amazing things that they're doing to help streamline this conversation. Now, the conversation that we're having today is about how do we educate our patients on what it is that we're seeing? How do we allow these pictures? What do they say? A picture's worth 1,000 words. How do we make this picture worth thousands and thousands of words and production dollars. And how do we do this in a way that removes subjectivity? Because if our patients aren't trusting us, they think there's a subjective nature, which, by the way, there is. When you take a look at some of these studies of, having multiple doctors' eyeballs on the same radiograph, you are going to get multiple different kinds of opinions. So how do we take this data and create an objective display? This is what our friends at Pearl have done and have done so beautifully. So this creates a really compelling narrative for the patient. Now it says, we've integrated this technology, and this is able to see it earlier, sooner, and faster. For those of us who are doing digital radiography, we remember when we were so excited to, take digital radiographs on our patients and show them in real time that radiograph just popped up, and we didn't have to go to the dark room to develop those films. Which, by the way, I still miss the dark room. It was a nice, cool little area. It was dark in there. It was comfortable. You could escape your patients for just a little bit, right? But now, instead of doing that, we're here showing this patient in real time what it is that we're seeing. And when digital radiography hit the market, we were so excited because it meant that we could blow up our radiographs. We could colorize them. We could flip them. We could do all these things with them. This enhances that. So now I, as a clinician, can show what this second pair of eyes is seeing. And now I can call out these areas of concern where I'm seeing advancement of that bone level, which is the second part of this. The fact that if our third party payers are going to push back and decline treatment because they don't believe that they, with their naked eye, their ability to see 30 to 50 shades of gray, if they believe that they're not seeing radiologic changes, they're going to deny that claim. So this now gives an amazing opportunity to submit this. Our front office team members know this well, to submit this to a third-party payer and to say, this is what an objective, high confidence level assessment is able to capture for us. Now, radiographs are step one to all of this. We know that. But the next step in this is capturing appropriate charting. And I love this image. This is an image of some probes in an office where I was brought in to do some consulting. The doctor in the practice recognized that they had a very low perio percentage. In the practice, when I first started working with them, they had a 4% perio number. So that means 4% of the patients that were coming into the practice were being treated with some kind of periodontal therapy, whether that was SRP, 4910, or 4346. Which means 96% of these patients, according to the office, didn't have periodontal disease. And the doctor thought that was weird. But at the same time, he said, my hygienists are saying we don't have disease in our practice. Everybody's healthy. I know my patients. I've been seeing my patients every 3, 4, or 6. I know my patients. So I know they don't have periodontal disease. Respectfully, as a hygienist who's been working in periodontics, who has spoken for the American Academy of Periodontology several times now, who has worked alongside the AAP as a partner, who brushes shoulders with the top periodontists in the country and around the world, as somebody who's dove into the data, I have yet to see data that says if you know a person, then you know if they have periodontal disease or not. Respectfully, the data that I've seen indicates that we actually do need to do assessments. Just because you know them, just because you know where they get their hair done, and just because you know that they, bake bread around the holidays, doesn't mean that you know if they have disease or not. So I go into the office and I take a look at the probes that they have in their office, and these were their probes. First of all, they're all different. There are various different kinds of bends to these probes, and it's hard to see, but they're even different markings. Some of these are the marquee probe, which is going to be marked every 3, 6, 9, 12. Some of these are like a modified UNC, where it's every millimeter marking, and then it hits 5, and then there's a band. So anyways, these were the probes that were in the office. And hygienists out there, you're all probably hopefully seeing the same thing I am, which is where are the colored bands? Like how do you know what a 3 millimeter looks like? How do you know what a 4 it looks like in these cases. You need to order new probes. So my first piece of advice, doctor practice owners, is if your probes look like this, it's time to order new probes for your hygiene department. And while we're at it and talking about ordering new probes for your hygiene department, there was a research study that was done that looked at what probe provided the greatest patient comfort. So this is a QR code that will take you to that probe. This is a UNC12 probe. This is from our friends at Paradise Dental Technologies. Other companies make UNC12 probes. Anyways, in this research study, they did a cross-sectional study where they specifically looked at, they calibrated the probing pressure, and they wanted to know what probe makes it most comfortable for the patient. Now, that's important because if patients are uncomfortable during the probing phase, that can create an issue where the patient maybe thinks that you're trying to make that probing depth, right? Oh, you were just pressing harder and trying to get that 5 or trying to get that 6. And so that uncomfortability, we believe, kind of influences or drives some of these issues. So at any rate, the data came back. Again, research study down at the bottom of the slide there, and it was denoted that that UNC12 probe gives the greatest patient comfort in calibrated studies, greater accuracy and better and more optimal calibration. Why? Because it's every single millimeter marking instead of the marquee, which is that 3, 6, 9, 12. So that UNC12 probe, again, here's that QR code to take you to, if you wanted to order or needed to order new probes, this is the QR code to take you to that UNC12 probe from our friends at PDT. So we know how important periodontal assessments are in the grand scheme of things. Periodontal assessments allow us to see the earlier signs, stages, or symptoms of disease. And that isn't just the world according to Katrina Sanders, although what a cool world that would be. This is the world according to the American Academy of Periodontology. So they specifically stated in their AAP proceedings, which those proceedings were written in 2017, published in 2018, when they did their staging and grading. They specifically said, if you're going to rely on radiographs to detect perio, that you are missing the earlier sign, stages, or symptoms of disease. You're going to miss those mild and moderate cases, which, again, those are the bulk of general practice patients. 47% of them, and a large body of those 47% individuals should be seen in a general practice having non-invasive, non-surgical therapy done. So if we're not capturing these appropriate assessments up front, this is going to create a challenge. This is going to create a problem. This, according to the American Academy of Periodontology, is what is considered a comprehensive periodontal assessment checklist. So you're capturing those probing depths. You're looking at bleeding tendency and or suppuration. Yes, that's one of my favorite things about working in perio is that we play with pus. We play with pus a lot. And it's one of the things that I love most. I know I'm a weirdo. Forgive me. We also look at things like recession points, furcation involvements, and mobility. That gives us the localized observation of potential perio. Then we have to look at the gingiva, color, contour, texture, consistency, enlargement, maybe patient reported complications like oral malodor or pain, and even deposit assessments. This is what a comprehensive survey should look like. And the American Academy of Periodontology says that the average patient should, at a minimum, have a comprehensive perio assessment performed annually. I'll say that again. The American Academy of Periodontology says the average patient should receive a comprehensive perio assessment annually. Now, patients who are at risk or have active disease or have a history of active disease where they are at risk are not your average patient. I'll take that back. They probably are your average patient because of how prevalent disease is. But what I mean to say is that is a patient who is at risk or diseased, where an annual exam is likely not enough to prudently evaluate and constantly be scrutinizing the level of disease our patients have. So the other side of this, or the other challenge of this, is that a large portion of patients who will delay treatment, switch dentists, look at a second opinion, or simply refuse treatment will do so because they don't agree with or trust our diagnosis. So that's a little shameless plug to, again, encourage you all to join us in 2 weeks for part 2, where we're actually going to dive into what do we do when we capture all of these assessments? How do we do or deliver an appropriate diagnosis? So stay tuned. Yes, I do actually need a large portion of time to make sure that all of you have the information that you need that's come down from the American Academy of Periodontology. So it's important to know that about 62% of the time, if they left your practice, if they got a second opinion from somewhere else, if they refused treatment, or they simply didn't schedule right then and there, it's because they didn't agree with or they didn't trust your diagnosis. Again, that is a tricky space to be in. So, one of the really incredible tools that we've had available to us, but I don't believe we have maximized in dentistry, is the integration of more objective diagnostics. This is a salivary diagnostic report from our friends at Microbe Link DX. This company is wonderful. And I'll tell you why. There are several salivary diagnostic companies on the market, and they all do different things. Salivary diagnostics is not just salivary diagnostics. This is a company that actually does, I should be a bit more specific here. Even though we call it salivary diagnostics, this particular company does more specifically gingival crevicular fluid diagnostics. So getting a saliva sample is kind of messy. If you get a saliva sample, you're getting whatever's been hanging out on the cheeks, whatever's on the tongue, whatever's back in the tonsil area, whatever's been splashing up on the palate. And so that gives kind of a complexity of a very broad range of the microbiome of the mouth. And that's beneficial in some regards. But when we're talking about periodontal disease and we're specifically talking about wanting to capture what that microbiome looks like in the subgingival space, we need to be looking at things like what does that subgingival microbiome look like specifically? So we can't just have somebody just grab some saliva in their mouth, spit into a tube and send that out. That does not give us good data. And unfortunately, you get things like candida and all these other funky little funguses and things like that that kind of interfere with a lot of the testing. The other thing that is really important about this particular saliva or crevicular fluid test is that this is actually a company owned by a dental hygienist, and it's called Microbe Link DX because her whole goal was to link the microbes in the mouth, link them to what's going on systemically, to help patients understand this is more than just a localized issue. So, yes, I understand that maybe patient Jeff, who came in, I'm just using Jeff as an example. Thanks, Jeff, for coming in today. You maybe don't think that these bleeding 4s and bleeding 5s are a problem because it doesn't hurt and all that other stuff. But you know what, Jeff, I'm concerned about the fact that you had high blood pressure today, which I know you're telling me you have white coat syndrome. Thank you for that. But you have high blood pressure. You haven't had your blood pressure checked by anybody in a very long time because I'm looking at your health history here. And it says you haven't seen a PCP in about 5+ years, which probably is longer based on what we know about the research of patients' perception of time when it comes to medical care and things like that. But even more so, Jeff, I'm concerned because you have high levels of aggregated Bacteremycetum comitans. You have high levels of Porphyromonas gingivalis. You have high levels of Tannerella furcynthus. And these bacteria we know are implicated in cardiovascular disease, just as an example. So it links those microbes or those bugs that we just siphoned from the patient's under the gum area. And that's important because when we talk about periodontal disease treatment, we're talking about doing an under the gum treatment. So we took this bacteria sample from under the gums, which is the area I would like to go to that you might decline. I want to go to the under the gum area. I want to get a sample and I want to look at that from a lab perspective and say, what kind of bacteria do you have? And ultimately, how is this bacteria going to potentially or could have already created major problems? So let's take a look at an example of this. Okay. And I just want to show this to show, previously some of the complications that we've had or that some of us might be currently doing that might be not fully coloring the picture of what we're seeing. So here's an example. Here's Kayla. She's 32 years old. Kayla comes in, we probed her, and she says, yeah, I'm getting bad breath. She's got 4 millimeter probing depths throughout the mouth, and she's got about a 36% bleeding tendency, which, by the way, according to the AAP, 30% or more of the mouth bleeding does in fact indicate at a minimum gingivitis, like true active gingivitis. And those generalized 4 millimeter probing depths, now we're wondering, is that gingival enlargement where it's gingivitis, or are we talking about stage 1 periodontitis? Previous method, that's what we're doing. We're looking at this and we're saying, you've got bleeding in your mouth, you've got bad breath, you've got 4 millimeter pocket depths. I'm concerned. Let's do this D4346 scaling in the presence of gingival inflammation. And the patient says, nah, I just want to do my regular cleaning. Well, if we take an innovative approach, what we're really doing is diving into the patient's motivators and ultimately their overall health. We're not just talking about treating the teeth, we're talking about whole body health. So, an innovative method would be taking a look at what's going on in that patient's health history from a more immersive experience. So, and again, these are just example patients. Kayla is currently exploring IVF because she and her partner have experienced a delay in conception. And we perform a under the gum salivary diagnostic test from our friends at Microbe Link DX. And we find that she has high levels or high concentrations of Porphyromonas gingivalis. As you'll see in a minute, the reports around these high concentrations of P. gingivalis, we've seen in the data that P. gingivalis, high concentrations of it in both the male and female partner, or one or the other, will delay conception, or there will be an increased time to conception. So now we're saying to Kayla, hey, I'm concerned. I don't mean to say that if we perform this D4346, that all of a sudden we're going to heal your condition of, conception. But what I do mean to say is this could be getting in the way of you having a more successful treatment. Let's look at some other examples here. Here's Julie, 58 years old. She comes in, we probe her. She's got, a couple of localized areas of 2 millimeter recession. She's got 4 to 5 millimeter probing depths. And look at that bleeding tendency at 45%. In 2 weeks, I almost said next week, in 2 weeks, when we do our, next part 2, we'll dive into this and we will diagnose her with stage 2 periodontitis. In the innovative model, if we could do things like capture greater assessments on that health history and even looking at family history, we could learn things like her mother had advanced stage Alzheimer's disease. And today, Julie's under the gum microbiota is presenting with high levels of Tannerella forsythis and Aggregatibacter actinomycetum comitans, which again is implicated in Alzheimer's disease advanced stages. So again, this changes the narrative from I want to do this under the gum cleaning to improve your probing depths to I want to do this under the gum treatment because we've got to lower these concentrations of this bacteria. Here's Marcus. Marcus, comes in not as good looking as we think he is because he's presenting with 5 millimeter probing depths, generalized 1 to 2 millimeters of recession. And here's that 56% bleeding tendency. Again, I, as a periodontal hygienist, have concerns about that. I do. If I were dating or married to Marcus, I would be concerned. I would be sending him in to have that evaluated. I would be telling him he needs SRP. But I believe I'm decently educated on perio. And again, one of our challenges is we need to help our patients understand, pun intended, the inflammatory nature of this disease. So we dive a little bit further into Marcus's case, and it turns out that grandpa was just diagnosed with stage 1 colorectal cancer, heavy family history of the prevalence of type 2 diabetes. When we do an under the gum evaluation of the microbiota in the subgingival space, we find high concentrations of Fusobacterium nucleatum and Aggregatibacter actinomycetum comitans. Fusobacterium nucleatum, there was a new research study that came out recently, but I will say that research study was not new. We've known this for a very long time. F nucleatum is oftentimes F nucleatum of oral origin is oftentimes detected in the colons of men who have tested positive for colorectal cancer. And we know that Fusobacterium nucleatum has a tumor genesis factor to it. So if there is a tumor and F nucleatum can get to that tumor, That F nucleatum allows the tumor to grow faster. So that could implicate advanced stages of colorectal cancer. So, and aggregated bacterioctomia symptomatins is implicated in diabetic cases. So, how do we approach this, or how do we integrate this in a completely different way? Okay. Here is the multi-step process. If you scan this QR code, it will take you to a site where you mention my name. You'll text Jennifer, she's the owner of the company, and just say, "Hey, I'm in Katrina's course right now." Just mention my name and say, "I'm in Katrina's course." She'll text you back. This will actually get you 10% off of your first 10 kits. Now, the kits themselves are actually free. The 10% that you get off is in reading the kits, or rather doing the lab work once you send them in. Okay. So you'll get the kits for free, all of them free of charge. That 10% off that you get is the lab fee to have these read. Okay. So we take a look at the six simple step process. Step 1 starts with taking these paper points. You get 5 little paper points and you insert them into the deepest sites in the patient's mouth. You let the crevicular fluid just kind of absorb, and saliva and the immunoglobulins and all that stuff. You let it all absorb into that paper point. You put it into the little tube, close up the tube, and then you're going to send this off to her lab. You send it express via UPS. Now, the process itself is actually quite fast. It gets shipped back. And when you send this back, you get the results within about 72 hours of Jennifer's lab receiving those results. So you'll get them, and those results create a customized report, which I'll show you in a minute, as well as a customized regimen in the event that antibiotics are needed. So you're going to go ahead and capture all this information. And again, when you capture this data, one of the most compelling things about this is not necessarily the antibiotic regime, in my opinion, but rather the kind of report that you get. So this is Jennifer's report that patients will get back. This is what I love. I'm going to start over here on the right side of the screen. So when patients come back and they present with, for example, high levels of Porphyromonas gingivalis, it talks about what the concern is. It talks about the therapy, and take a look here, friends. This is like what I love. Again, she's linking these microbes to overt issues. So here, you're going to see these little icons. If one of these icons is listed underneath that bacteria, it means that the research has already definitively linked that particular pathogen to that systemic issue. Okay, so let's say that my patient has a family history of diabetes. So I'm concerned that my patient could be pre-diabetic. If they have inflammation in their mouth, there's a high chance or high risk that patient could have diabetes. We know that periodontal disease and diabetes are a two-way street. So now I want to look at your pink complex, your AA. I want to look at our red complex. Look at this. P. gingivalis, T. forsythia, T. denticola, all implicated in diabetes. F. nucleatum implicated in diabetes as well. These green complex she looks at, and that's a conversation for another day, because green complex can be either health or intermediate bacteria bugs, but she captures those as well, which, by the way, I absolutely love. So now I'm telling my patient, hey, look at this. This test came back and you have high levels of these bacteria, which are implicated in these kinds of diseases, which are areas of concern. We need to talk about these. We see pregnancy complications. So my patients who are trying to conceive, going through IVF, freezing embryos, whatever's going on in their world, that's going to be an important driver for them. And again, cardiovascular disease, Alzheimer's disease, et cetera. Is there opportunity to expand this out? Of course. And that is what I love about what Jennifer's doing, is she's always staying on top of the research and, again, linking these bugs to serious health conditions. So this is step 1. But for me as a periodontal hygienist, here's the other side that I want to look at. I want to look at this column, or this row here. These are SRP resistant bugs. So what she's doing is she is taking a look and genoming the kinds of bacteria in the mouth that are going to be resistant to SRPs. Yes, there are bacteria in the mouth that even if I perform non-surgical SRP on this patient, that these bacteria are going to be resistant to that. So I now need to integrate or incorporate other therapies or modalities. So the challenge that I've had in the past, or rather the challenges that people have had, I believe in the past when it comes to looking at salivary diagnostics, is that doctors will say, Katrina, you don't understand. I send these salivary diagnostics out, I get back, and it's the same antibiotic regimen no matter what. Every patient comes back with amoxicillin and metronidazole as the cocktail of what I should be prescribing my patient. Okay, I get that. I get that. And I understand why you would stop doing salivary diagnostics on your patients. I understand that. However, to kind of take this a step back, and again, on this regime, please consider utilizing this QR code. And again, this will allow you to send a quick text message to Jennifer. Just say, I'm in Katrina's course right now. I want more info. She'll send you everything. I promise. You'll get free kits, and then you'll get that 10% off of reading your first kits. So here's the other side of it. And this is what I love about what she's done. It's not just about the antibiotic regime. It's about identifying, does my patient have SRP resistant bacteria? Because if they do, now I need to add things on. I need to do things differently. These are patients that we need to take seriously. I'm not going to say that they are a grade C or progressive diseased case. Stay tuned again in 2 weeks. I promise we'll talk about that. But what I do mean to say is if I see that my patient has heavy loads of SRP resistant bacteria, I'm not going to get the outcome I want just by doing SRP. I now am going to use this as a guide to say, we need to be looking into other modalities. Okay. So here we are. Let's go back to the appointment. You just sat down with your patient. They came in for their free 6-month cleaning, their insurance covers, blah, 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 all this stuff, right? You just sat down with your patient. You're going through all of this, right? And you've done the assessments, you've done the radiographs, you've done all the charting. Doctors come in, done the exam, agreed with your diagnosis. Hopefully your doctor is agreeing with you on your diagnosis. If you and your doctor are not agreeing, see me back in 2 weeks. We'll talk about diagnosis. Can you see all these shameless plugs here? So you've gone through all these assessments, then you look at the clock and you go, all right, so I've got 25 minutes left. Ooh, what am I going to do with that 20 to 25 minutes? We now know that performing a prophy, creates complications of treatment success. You don't get better outcomes with it. And in some cases, I do believe that it sends the wrong message to the patient. So now what do we do? What do we do with the rest of our time? Well, here's what I'll tell you. I believe that we have an amazing solution in our arsenal. And that solution is diving into a consideration of integrating true wound care. So we talked about SRP resistant bacteria. And by the way, my apologies for zipping through the slides here. Jennifer's report also captures tissue invasive bugs. So those are going to be bugs that have in fact or have the ability to invade the tissue and line that periodontal pocket. So this is where we need to be a bit more focused, not just in treating the hard tissue, but also focusing on that soft tissue. This QR code here will take you to a site where you'll actually be able to explore this treatment in a more immersive way. Tons of resources on there, as well as how can you find magic production in your hygiene column, in your filing cabinet. So there's some free resources there for you. But one of my favorite free resources that's available on this QR code is the ability for you to explore the PerioProtect custom periodontal tray system for free. So what we're talking about is the concept of integrating a custom tray that is designed and made for your patient to deliver wound care medicine or medicament directly into that ulcerated pocket lining. So again, that invasive tissue, that bacteria rather that has invaded the tissue sitting in this area, we're not going to be able to get through an SRP or a true debridement. So this is where we want to take a look at how can we get medicine that gets placed directly onto that wound. Now, when I was a child growing up in Milwaukee, a small little suburb of Milwaukee, I was one of those kids. I was kind of a tomboy, and I love to ride my bike, and I love to, go in the woods and explore things. And it never fails. I'd go out running around in the neighborhood, and I'd come back with my, knees all skinned up, bleeding like gravel in it, from the sidewalk. And I fell on the side, blah, blah, blah. Thank goodness I was always wearing a helmet. Uh, I attribute that helmet to why I can still remember all of these research studies today. So thank you for helmets. Always wear your helmet. Anyway, I would come, skinned knees and all that. And one of the first things that my mom would do when I had these open wounds on my leg or whatever was she'd get out the brown bottle of hydrogen peroxide and she'd pour hydrogen peroxide on the area. And then she would, put a Band-Aid over it with some Neosporin on it. She'd put medicine on the area. She'd cleanse the area and she'd make sure that that wound was protected. Well, unfortunately, in dentistry, it's not common practice for us to do that. Now, I'll tell you, the concept of cleansing a wound and keeping medicament on it for it to scab over is an important wound care consideration. My sister in the foot and ankle space, when she's doing diabetic foot ulcers and things like that, she is addressing this with her patients. So, those wound care considerations or medical wound care guidelines have been established for a long time. We in dentistry haven't looked at them. And I will say I don't really understand why we haven't, because periodontal disease is a wound disease. It is an ulcerated infected wound disease. And for the most part, we've really been treating it by taking the proverbial sliver out of the area and then expecting it to heal on its own. Meanwhile, the mouth is warm. It's everyone's favorite word, moist. It's got changes in pH levels. The microbiota love to repopulate. We're constantly feeding it with food and all the things that we're doing. So it's not really a protected area. And I know we'll talk in a minute about, self-applied care and in my opinion, the best tool to, if we can get something in our patients' mouths to debride, that it's going to help exponentially in trying to keep some of the oral cavity biofilm free. But we're relying on our patients to perform self-care. And I don't have a slide on it right now, but it's important for me that you know that there is incredibly compelling data that says that our patients are not following our recommendations to brush with an electric toothbrush for twice a day for a minimum of 2 minutes, then use some kind of interdental care, whether that be floss and interdental brush or a combination of them, or water flossing or mouth rinses, etc. Like there's compelling data that says they're not doing it. I don't mean to say none of them are doing it, but I do mean to say a large portion of them are not doing it. Part of the challenge is our patients are deeply motivated to do things that help improve things that they care about. Like they'll use mouth rinse because they get fresh breath with that mouth rinse. They'll chew gum because it gives them fresher breath. Or they'll use those custom whitening trays that you made them. Why? Because they're going to get whiter teeth. So the concept of these trays is kind of amazing because what it's done is it's created an opportunity for us to create a custom tray system. I'll show you what that looks like in a minute. That custom tray you load with the hydrogen peroxide gel that they give you. It's a gel concentration. At a 1.7% concentration, we get incredible efficacy downward into that subgingival space. And from there, patients have actually found, yes, because it's hydrogen peroxide, they get whiter teeth and fresher breath along the way. So, okay, this is what the tray system looks like. Do you see how the tray gets seated down? And as it seats down, it kind of expresses or pushes the gel into that crevice, into that subgingival space. And it holds the gel in that area whilst the patient is wearing these trays. So we've found that, yes, the patient has amazing localized benefits, reduction in bleeding scores, reduction in gingival inflammation, etc. Then we've also found that the patients find that they get fresher breath and whiter teeth from it. So cool. That actually means the patient is going to be more compliant. And one of the things that we find when patients are placed on these custom PerioProtect trays, you get a tray for the maxilla, tray for the mandible, and then you get a tube of that gel. When patients use this, that they are more compliant, that they will prefer to use their custom trays. They'll wear their trays when they're in the shower. You'll wear it for about 10 minutes a day. You're good to go. And that contact time is enough for us to get greater efficacy. So we love that. And then we've also seen some amazing systemic improvements. So it turns out even if you cannot mechanically scale a patient. So they've seen some case studies or data where a patient, for example, was diabetic and they just had a heart attack and the cardiologist said, please don't scale the patient until 3 months have gone by from that heart attack. but the office still wanted to do something to try to reduce the biofilm, particularly in that subgingival space. These patients, when they've had these custom trays done, no mechanical scaling, that we've actually seen their A1Cs reduce. And we've also seen cardiovascular disease markers reduce as well, which is amazing. So this becomes an opportunity. The question is, now what? What do we do? You got an extra 20, 25 minutes? Now, what you do is you take impressions or you do an intraoral scan so that we can start sending these out to the lab, have these custom PerioProtect trays designed for the patient. So when they come back in for their first appointment following the initial diagnosis, that we can deliver them those trays. Now, that's one critical opportunity. Another important opportunity that I did want to call out or share is the complication around the treatment of periodontal wounds. Now, it's important to know that what we're looking for when a patient has inflammation, so this is your gingivitis cases, which, by the way, PerioProtect trays, although it's called PerioProtect, have excellent, excellent, excellent efficacy and benefits for patients with gingivitis. So if we're talking about a D4346 patient that we need to treat, we hope to see a resolution of inflammation in about 2 weeks. The average patient, the average healthy patient with a healthy immune system, we should see that resolve of that inflammation in about 2 weeks. For an SRP case, remember, we want inflammation to reduce and we'd like to see gain of that clinical attachment. That gain of that clinical attachment typically will happen about 4 to 6 weeks after subgingival scaling and root planing has been done. So part of the challenge is that when we take a look at the result of initial SRP and oral hygiene instruction, that we see localized improvement, but we do not see a complete elimination of inflammation and a complete resolve of the disease process. And we know that if we bring patients back in for a reevaluation, that there will be some localized areas where we may have to go back and do a fine scale. The goal is to, of course, eradicate that inflammation as best as possible. And one of the challenges that we've seen is that with patients who continue to demonstrate a return of inflammation, that these are patients that do in fact have active periodontal disease, and maintaining them with a 4910 is not appropriate. We need to be considering some kind of advanced periodontal therapy. Again, these are typically patients who presented with high levels of SRP resistant bacteria. So when the patients are coming back and we're still seeing a presence of disease, we need to be thinking outside the box. Now, this is where I started to explore, as a periodontal hygienist, the opportunities to actually influence my patient's immune system. I do see patients in a perio office who have rheumatoid arthritis, who have cardiovascular disease, who have diabetes, who are HIV positive, who have AIDS. I mean, I'm seeing patients where there's an immunocompromised status to the immune system. And part of what I'm doing when I'm performing a debridement is I'm trying to stimulate that immune system to get it to start working. So, I had concerns with a lot of my patients having a delayed immune system. I would do a D4346 on them, or I would perform a active perio treatment. I'd bring them back in for the re-eval, and they were non-responsive. And what I did was I blamed their immune system. And I'm sure many of you blame that immune system. Oh, we didn't get the result we wanted, but that's because of your diabetes. That's because of your diabetes. Ooh, well, there's a challenge there, because you know what I just did in that initial exam? I told the patient that if we could perform debridement, we might be able to improve that patient's diabetic condition. So now I'm going to blame that diabetic condition as to why I didn't get the results I wanted. And then I'm going to tell the patient, as long as you're diabetic, we're probably going to have these problems. And that's the best that I could offer my patients. That didn't seem right. I'm a preventive specialist. I'm an inflammatory specialist. That didn't seem right. So I started to explore or study the role of other kinds of health producing or health improving modalities on patient care. And this is when I came across probiotics. So this QR code will take you to a page where you can actually connect with my favorite probiotic, that is ProDentis from our friends at BioGaia. This will take you to a QR code where you can order samples, free samples to be shipped to your office, and to set up a lunch and learn with the amazing BioGaia team so that you can actually talk to a team member about how you can integrate these probiotics into your clinical practice. Okay. So when we talk about probiotics, many of us have learned about probiotics as it relates to gut health, but many of us don't fully understand that the mouth is the opening of the gut. Many of us also realize that the oral microbiome can drive some of the gut microbiome. We've seen that oral gut axis happen. We're still trying to study where it's coming from. But we know that having a microbiome that is dysbiotic in the oral cavity creates issues with gut health. So we've studied that. The challenge that we've started to see is that when probiotics have really only been driven or utilized for gut health, that we've missed the opportunity to explore the fact that the microbiome is well studied in other areas. There is, there's microbiome on the skin. There's microbiome, in other areas of the body that our OBGYNs are studying and things like that. So the microbiome in different areas of the body become really important. But the mouth and the gut being linked creates an important aspect to this. Well, it turns out there are probiotics that have been designed or are well implicated for oral health. These are probiotics. Pro means for. So these are bacteria that help or are for life-sustaining modalities. These are health-producing bacteria. So there's a question that I love to ask audiences. Can you have a biofilm that is a healthy biofilm? And the answer is actually yes, you can. It is deeply rare, but you can. And if you have a biofilm, like take a look at this patient here, which by the way, I'm sure hygienists, are you just like sitting on your hands right now? You just want to like get an ultrasonic on that and just blow that out, right? But when you take a look at this biofilm, we see the reaction in the gingiva. So I'm assuming this is a biofilm that is dense with disease-producing bacteria. But if this were a biofilm that was dense with health-producing bacteria, we would likely see zero reaction. In fact, we would see impeccable health. So it is possible to have a health-producing biofilm. It's just quite rare. And why is that? It's because the vast majority of us are now born with a microbiome that is quite devoid of health-producing bacteria. We've studied this over time. People are born with legacy bacteria that's been given to you, in utero. So if mom was resistant to, has bacteria in her body that was resistant to different kinds of antibiotics, that's going to be passed down. We use antibiotics a lot. We use antimicrobials a lot in healthcare, in dentistry. Growing up in Milwaukee, I had ear infections all the time once the winter rolled around. And so I was on penicillin, like the bubblegum stuff, like all the time as a kid. So what happens is it starts to strip the human body, the commensal microbiome of health-producing bacteria. So most of us should have been born with health-producing bacteria, but because of the delivery mechanisms of modern medicine, we've actually stripped a lot of that out. So when you look at Jennifer's report of SRP-resistant bacteria, it's important to know that many of us now are considering that maybe that doesn't mean that we're looking at an antibiotic regime. Maybe that means we're looking at integrating probiotics, health-producing bacteria. So the data has been compelling. First, we know that probiotics or health-producing bacteria can colonize the plaque. And when they colonize the plaque, like if this plaque, this materia alba was dense with these health-producing bacteria, that we would see a massive reduction in bleeding tendency. We would see a massive reduction in inflammation. In addition, we find that when patients take oral probiotics, that these oral probiotics, or rather the health-producing bacteria, compete with disease-producing bacteria to try to adhere and mature the biofilm. Interestingly enough, the probiotics actually win. The probiotics win. So when that occurs, when the probiotics are able to colonize this microbiota, we find that there's actually a reduction in plaque scores, because now we don't see that mature plaque bulk up. The question really stems from when we're using probiotics, are all probiotics the same? And This was a research study. This is actually a screenshot from this research study that was published in the Journal of Clinical Periodontics. There are all different kinds of probiotics that are on the market. Clinically, the bacteria that the Journal of Clinical Periodontology published that is in fact the most optimal, gives the statistically significant benefits in many meta-analysis studies, is a probiotic that contains bacteria of Lactobacillus rhodori. Back in 2020, they called it Lactobacillus rhodori. Now, our friends at BioGaia, with their strain or their line of bacteria, call that a Lactobacillus rhodori, which means that this is a bacteria that oozes or releases ruderin, which is an antimicrobial. So yes, what you're literally doing when you're giving your patients specifically probiotics, some of these have different kinds of active strains in them. But again, these active strains in these other probiotics do not contain L. rhodori, the bacteria that is implicated or noted to give statistically significant success. So your BioGaia, your ProDentis, contains 2 strains of your Lactobacillus rhodori. And yes, when you give your patients these probiotics, you give the patient the opportunity to now have those bacteria, those health-producing bacteria, release antimicrobials to help naturally augment that subgingival microbiota and help improve outcomes, which improves the oral immune system. And these are lozenges that the patient chews and then swallows. We know that 80 to 90% of the immune system thrives in the gut. So now these bacteria, are health-producing bacteria, are being swallowed and entering into that oral gut axis. Again, here's that QR code. If you have questions or have an interest in learning more about getting connected with the BioGaia team, this screen shows you what my protocol is. They have a liquid form of the probiotic. That liquid form is designed for children. You can give it as early as the first day of life. And it's designed as a liquid. Why? Because the assumption is that they were born without teeth. But we want to be able to get health-producing bacteria immediately into that oral microbiome. But you can also use these as either in a micro brush or a subgingival irrigant, and you can actually place these drops into that subgingival space, allowing for these health-producing bacteria to recolonize the sulcus and deliver beneficial bacteria. I send my patients home with the lozenges. So you can either dispense them in office or they can get them on Amazon and they can just do a subscribe and save. And that's probably the easier way to do it for a decent portion of your patients. Just do that subscribe and save. And so if the patient is at risk, you get 1 tablet a day. Patients who have active disease will take 2 tablets or lozenges a day, 1 in the morning and 1 at night. So these are going to be things I would begin my patient with early on. You're still in that appointment, right? You've got 20 minutes left after you've done all your assessments. You capture that intraoral scan on the patient. You educate the patient about some of the things we want to do to boost that immune system so we can start to get optimal results. And the final step in this process is driving home that patient self-care, counseling the patient on the various modalities or aspects of self-care that we would like to drive home or help support our patients in. So again, we're taking that remaining amount of time and saying, we're going to be working very hard. We've got a treatment plan put together for you that will begin starting treatment. I want to make sure that we're boosting up that immune system. We're taking impressions. We're getting a survey of what the bacteria in the under the gum area look like. But we really need to make sure that you're doing your part at home. And there are a million different ways that we can do that. Again, these oral probiotics we talked about, those custom perio trays are going to be super helpful. But to get the patient started, we really need to make sure that we're giving them something that should hopefully help augment that oral microbiome long term. And there are many different things that we do, like electric toothbrushes, water flossers, interdental aids, right? The goal being we want to give our patients something that is going to help them to control their own level of disease. And so I will say this is perhaps the most satisfying video you're going to watch today. As a periodontal hygienist, I cannot say enough about the data around water flossing. The data around water flossing, and by the way, this is data from our friends at Waterpick. The data around water flossing shows that truly, if you can get a water flosser in your patient's hands of anything, that we are going to see incredible clinical benefits. So again, your data is right here, down in that lower left area. This data is from our friends at Waterpik. So I know there have been some incredible data that's come out about, the improvement of our electric toothbrushes, pastes, and things like that. I don't mean to say that they don't provide improvement, because they do. But if there's one thing that I stress to my patients to use, it is their Waterpik water flosser. And here's why. First, the Waterpik water flosser is significantly more effective than string floss for removing plaque and for the reduction of gingival bleeding. It is statistically more significant. Waterpik water flossing is also going to be significantly more effective than the use of interdental brushes for the removal of interdental plaque. This is what blows my mind. The Waterpik water flosser is also an effective alternative to using subgingival antibiotics. Yes, when periodontal maintenance patients had either subgingival antibiotics with the delivery of 1 milligram microsphere minocycline, which is our Arrestin, when they received antibiotics, or the other group, the test group, received water flossing, both groups demonstrated the same clinical outcomes. So, if my patient is hemming and hawing because they don't feel comfortable with maybe having all of these sites of subgingival antibiotics, is there something else I can give my patient that could give me clinically significant results? Yes. And this is where I build trust with my patient in saying, listen, if you don't want this, I understand. This has given similar benefits. So if you are interested in doing something at home and we can trust that you're going to utilize this regularly, we can see some optimal benefits. In fact, the Waterpik water flosser has actually shown statistically significant reductions in biofilm gingivitis and bleeding tendencies, even with patients that have delayed wound healing, like our diabetic patients. So this is the final step in that process. Is my patient walking out of the appointment after having impressions or scans done for perio trays? They're walking out with probiotics in a capsule, or they're walking out with a subscribe and save recommendation for probiotics. Is my patient walking out with a Waterpik in their hand and a direct plan of what it is that we're going to do to start augmenting that immune system and start controlling that biofilm before we get treatment started? You betcha. My patient is walking out the door with a list of things to do that I have customed and designed for them, as well as, I believe, understanding that there truly is a seriousness to this disease process. So, to kind of do an overview of this patient-centric workflow, the workflow that we went through today, let's take a look at the current model that most of us are doing, which is patient comes in, we perform that health history review, we update radiographs, we update our clinical assessments, we 323 them. Doc comes in for a recare exam, confirms our diagnosis, and we discuss periodontal therapy. We identify the patient needs periodontal treatment, etc. So currently we billed for radiographs and that exam. And in that current model, we typically have, a couple of common modalities that can happen. So the first common modality that we can see is the patient says yes, and maybe we try to squeeze in a quadrant of SRP that day. So in that model, patient says yes, and we move forward with starting a quad that day. We've produced in that appointment about $321 to $371, and we've got the next visit all set up, 3 quads of SRP. Potential fear of denial, though. That's always the concern, that our radiographs could not be demonstrating appropriate levels of disease, and we're going to have an insurance denial. And our cost is the doctor's overhead. The other side of this, the other concern, is the patient says no. And if the patient says no, what do some practices do? They move into that signing of an informed refusal. We perform that prophy, which costs $99.47. So it costs the office overhead and a major liability, but we brought in $222 during that appointment. And we've got that patient now next visit on their 6-month hygiene recare, where we're going to try this whole hamster wheel over again. What I'm proposing is that we consider an innovative model. And inside of that innovative model, yeah, you're doing the health history review, but this time you're going to update those radiographs and you're going to integrate AI technology. You're going to update those clinical assessments. You're going to do that recare exam and you're going to confirm those findings. And I implore you to consider that now you have this next step in the process, with which, if you engage and work with Jennifer, she will help you with all of the appropriate codes and fees that you can use for appropriate salivary diagnostics. So now you're capturing an assessment and then you're sending those salivary diagnostic pinpoints out to a lab and having that reviewed. Now you are billing additional fees associated with that salivary diagnostic capture. Then you're performing an intraoral scan, and that intraoral scan or impressions will also help you to capture custom periodontal trays. There's your CDT codes for that maxillary and mandibular custom perio trays. Here's your average UCR, average fee that a practice is charging for those. You're going to spend time discussing oral hygiene instruction. You'll talk to your patient about probiotics, boosting that immune system, maybe dispensing products. Again, my favorite product to dispense is that water pick. And then in that entire appointment, you have maximized that amount of time getting the appropriate assessments that you need, beginning or getting commitment from the patient to move forward with some of these advanced modalities that are going to help to address the SRP resistant or tissue invasive bacteria. You're getting the patient on an oral hygiene routine that is going to help to improve your clinical outcomes. And now your treatment coordinator has the time to sit down, educate the patient, and schedule that patient for the appropriate treatment that's necessary. So now there are some costs, right? You've got overhead, you've got the fees, Jennifer's fees that you will have to pay in order to have the lab read those, and then Perio Protects fees associated with having those custom Perio trays made. But the reality is now you've got a pipelined patient that will essentially give you production. By the way, in this first appointment, now you're producing $1,200 to almost $1,400. That's just in your first appointment. Then you're bringing that patient back in for 4 quads of SRP. And now you have radiologic evidence. So now you are preventing the risk of a denial. So again, when we take a look at the comparison here, yes, if you start treatment same day and you do just that 1 quad of SRP, which a decent portion of practices are doing, you're producing about $320 to $370 in that appointment. And the idea here being moving into an innovative model not only gives you the time to connect with your patients, it also gives you the opportunity to bring in and maximize production, improving clinical outcomes, and continuing to build trust. I'll tell you, many of you think a patient's not going to pay $1,200 for all of these things and just to walk out with a water pick in their hand and coming back in for custom trays. I'll tell you that's actually not the case. Patients report on average they would pay about $633 a tooth to prevent that tooth from being pulled or extracted. So it's important to know as we round out today's program, as we take a look at some of the goals that we hoped to capture or maximize, that my hope is that you started to identify some of the ways that we can take control over how hygienists particularly manage their time when it comes to these in-between patients, that we have the ability to impress our patients when we have these innovative tools available to us, that we have the ability to produce valuable treatment that will move our patients as close to 100% health as possible with optimal treatment outcomes that are really designed or driven to improve the lives of our patients. Again, here's that QR code that I shared earlier. That is a free webinar that I've recorded that goes through the 2025 CDT codes and gives you kind of an overviewed framework about how to start delivering care to hygiene patients. So if you found this valuable, feel free to scan this QR code to be able to, of course, participate inside of that free webinar that I've recorded. I will conclude my program by thanking the amazing team at ACT Dental for their unwavering support and for always, always, always making me feel like a part of the family. I also want to thank the amazing partners who provided educational grant for today's program, including our friends at PerioProtect, BioGaia, MicrobeLink DX, WaterPick, and Pearl. I'll conclude with this quote from Lou Holtz, who says, I follow 3 rules: do the right thing, do the best you can, and always show people you care. That's what this is about. It's about doing the right thing, showing up as our best, challenging ourselves to push ourselves to what our new best could look like. And at the end of the day, creating an opportunity to show our patients truly how much we care. With that, I want to thank you all so much. If you enjoyed what you saw, feel free to connect with me. I'm on Instagram at The Dental Wine Genist. You can find me on Facebook at The Dental Wine Genist. If you have any questions, feel free to connect with my team. And this QR code will just take you to my Instagram page so that you can follow along on all of the wonderful journeys of things that I do. I post educational content on there all the time. I post fun content. I post wine tasting content, all that fun jazz. So please feel free to follow me or connect with me if you have not already. With that, I'm going to turn the microphone back over to Angela and the amazing ACT Dental team for further steps.
Katrina, we're so thankful for you. That was amazing.
My pleasure. As always, my pleasure.
And you can also get the mulled wine recipe on your Instagram.
That's right. Yes, my glühwein recipe's on there.
Oh, that's awesome. I tried to actually do that while you were talking, and for some reason my computer thinks that I've never logged in before. So I'm gonna have to do that. Gonna have to do that from my phone. Yeah, that's awesome.
Gotta love that.
I do have a few questions in the chat. I know we
Yeah.
only have 5 minutes left, but maybe we could answer 1 or 2 of them.
Yeah.
And everybody, come back in 2 weeks. We'll continue this conversation, so it'll be amazing. The first question I saw come in was from Marcy. She says, I know you will probably cover this in 2 weeks. In our office, we're struggling to know what to do with the 20 to 30% BOP patients, especially when you can look at their gums and know they are going to bleed as soon as you touch them with an instrument. What would you recommend for their treatment?
That's a fabulous question. Yeah. And thank you, Marcy, for setting up that wonderful question, because that is absolutely what we are diving deeper, pun intended, into when it comes to the diagnostic piece in 2 weeks. So we will be walking through that. I want to give you an answer, but I want to make sure that it's the correct answer. What I will tell you is that when we see large bleeding upon probing with our patients, that is in fact active disease, and we do need to be addressing that. What we do when we address that, that's what we're really going to be diving into in 2 weeks. And that really stems from identifying, is this a gingivally diseased case? Is this a periodontally diseased case? Is this a periodontal maintenance case that maybe needs to be re-entering back into active therapy, et cetera? So I'll be walking through some of those decision-making modalities, but we're going to be talking specifically about what, if we see these assessments, what does that diagnosis look like? And then ultimately, we'll go back to some of the things we talked about today to help support what our treatment is, because that bleeding, that tissue invasive bacteria, we have to start doing other things aside from just scraping the teeth.
Thanks, Katrina.
Yeah.
Lucy wants to know any thoughts on the recent backlash to hydrogen peroxide. I admit I have to do a deeper dive into the concerns, is what she says.
Yeah. Well, thank you. Hey, Lucy. Fabulous question. You're obviously with it enough to know that there is some backlash around hydrogen peroxide. So the first backlash really was that if the patient was taking in high concentrations of hydrogen peroxide, that over time and over chronic exposure of it, that it would change the oral microbiome, or in some cases, they were saying, well, I'll get to that in a second, that it was going to change the oral microbiome, could even elevate the patient's risk for like cancer and things like that. Well, that's with a higher concentration of hydrogen peroxide, which some people are using upwards of like a 10% hydrogen peroxide. What we're talking about with the PerioProtect tray system is a 1.7% hydrogen peroxide. So it's a lower concentration, but it's placed inside of a gel. So it's got that thickness to it to actually remain in the area, not just flush out of the area, which is one of the challenges we see when we put liquids down in the subgingival space. It's just going to flush out, but the gel is going to go in underneath there. And with that 1.7% hydrogen peroxide, they've done the data forward and backward. With the concentration of that hydrogen peroxide from PerioProtect, we are not seeing the negative effects of that oral microbiota. PerioProtect's been around for decades. So we have long studies on it. We haven't seen those adverse effects happen. So we believe it's because of the lower concentration of that hydrogen peroxide. However, there have been some competitors that have entered the scene that do similar things to what PerioProtect is doing, but they're selling it on Amazon. It's not a custom tray, and their gel concentration, although it has hydrogen peroxide in it, it has not gone through FDA, clearance and things like that. So it's just a hydrogen peroxide gel. And there actually is some very scary data about what's happening with individuals, with folks who are utilizing that hydrogen peroxide gel, because of the additive products that have been added to the hydrogen peroxide gel they are getting on Amazon, et cetera. We've actually seen reactive oxidative species, which we know allows for the development of cancerous cells, starting to increase. We've seen major tissue sloughing issues. So the backlash around hydrogen peroxide as a whole has been a challenge that the folks at PerioProtect are still trying to work through, because they've done the right thing. They've done the research. They've gotten the formulation. The formulation is low enough that it doesn't create adverse issues. The patient can routinely use it. It doesn't create damage. It shows amazing clinical efficacy. But to your point, Lucy, and thank you for even admitting, like, hey, I think we need to do some deeper dive in this. Not all hydrogen peroxide is the same. As we learned with, not all probiotics are the same today. So thank you for asking that question.
Thank you, Katrina. And I took a screenshot of some of the other questions that have popped in, so I'll send those to you, and hopefully you can work them into your presentation for part 2.
Thank you. And I look forward to coming back for part 2. I want to make sure that I clarify a few things. Pamela, the probiotics that I discussed, that L-Rhodorite, that is over the counter. So they can get it, they can order it on Amazon. They can have it shipped to them. It doesn't need to be, it's not prescription. No probiotics are prescription. These are the health producing ones.
Thank you, Katrina.
Mm-hmm.
All right. Well, we will see everybody back in 2 weeks. So enjoy your festivities. Thanks. Bye.
Bye-bye.